Good afternoon, everyone. Thanks for joining. My name is Clare Moran. I'm a nurse practitioner here in the hospital in the Department of Radiation Oncology, and I'm the Survivorship Coordinator for Stony Brook Hospital. So I see a lot of the patients when they're finished with radiation and talk to them about survivorship. I go over the treatment summaries with them, their care plans, and help them transition back into primary care. So what I plan to do today is go over the survivorship guidelines for assessment, as well as monitoring long-term effects of cancer and its treatment. This is just the funding acknowledgement. I have no financial interests or relationships to disclose, and this conference is being recorded. So the educational objectives for today, we're going to talk about cancer survivorship and its importance. We'll discuss the role of the primary care provider in the care of the cancer survivor. We'll review general survivorship guidelines per the National Comprehensive Cancer Network recommendations. We'll talk about late and long-term effects of chemotherapy, immunotherapy, and radiation, as well as late effects and long-term psychosocial and physical problems associated with cancer treatment, as well as discuss the role of survivorship care plans. Cancer in New York. So the number of people living with cancer in New York State has been steadily increasing each year. Approximately 115,000 New Yorkers are diagnosed with cancer each year. And in 2017, New York State ranked fourth among the 50 states in the overall cancer incidence, with approximately 1 million living New Yorkers having been diagnosed with cancer. And what does this mean for the country? So if you can see looking at this graph that the trajectory of cancer survivors is increasing, and it's approximated that in the year 2040, we'll have 26.1 million cancer survivors. So what makes cancer so different? It's not a single disease. It's a collection of over 100 different diseases with complex treatment, toxic treatment. It's costly. The treatment can span over multidisciplinaries. It can be poorly coordinated at times, and it occurs in isolation from the primary care setting. What is survivorship? So survivorship focuses on the health and well-being of a person with cancer from the time of diagnosis until the end of life. This includes the physical, mental, emotional, social, and financial effects of cancer that begin with diagnosis, continue through treatment, and beyond. It includes issues related to follow-up care, late effects of treatment, cancer recurrence, second cancers, and quality of life. Family members, friends, and caregivers are all considered part of the survivorship experience. There's no clear consensus on when survivorship begins. It's generally thought to be considered the time when treatment ends and your patient has no signs of cancer. It lasts until there's a recurrence, a second cancer, or death. The National Cancer Institute looks at it from the time of diagnosis until the end of life. The American Society of Clinical Oncologists talks about it as a time that begins when active treatment ends. And then the Institute of Medicine refers to long-term survivors as those individuals who have survived beyond 5 years. Survivorship has 3 phases. There's an acute, extended, and permanent phase. The acute phase starts at diagnosis and goes through the end of the initial treatment. And during this time, the cancer is the primary focus. The extended survivorship starts when initial treatment ends and goes through those first few months afterwards. And during this time, the effects of the cancer treatment are the focus. And then permanent survivorship refers to a time period when a few years have passed since treatment has ended. There's less chance for cancer recurrence, and the focus now is really on the long-term effects of cancer and its treatment. So why should we discuss survivorship? Cancer survivors are at risk for significant physical, psychosocial, and financial repercussions from cancer and its treatment. Some cancer survivors recover with a renewed sense of life and purpose, but the long-lasting effects on health functioning, sense of security, and well-being are often ignored. Cancer affects the patient, their families, caregivers, and entire communities. It never leaves the patients the same. Recovery from treatment can mean many different things depending on the type of treatment, depending on how they responded to treatment, and also depending on what their baseline health was before they got treated and what is their new baseline upon the completion of treatment. The long-term effects of the disease and its treatment affect a patient's health, well-being, family and social relationships, and economic productivity. In 2006, the Institute of Medicine issued their report From Cancer Patient to Cancer Survivor, Lost in Transition, to address survivorship needs. They stated that survivorship care was a neglected phase of the cancer trajectory, and they made recommendations to improve the quality of care for cancer survivors and to transition them back into primary care. The report also emphasized the importance of a smooth transition from active treatment to post-treatment care and its role in their long-term health. If care is not planned, cancer survivors are left without knowledge of their heightened risks and a follow-up plan of action. Such a plan is essential to ensure that during routine follow-up visits, these follow-up visits become opportunities to promote healthy lifestyle, check for cancer recurrence, and manage any lasting effects from cancer treatment. So what is the role of the primary care provider in survivorship? Despite clinical guidelines and survivorship care plans, it remains unclear how the follow-up needs of survivors should be prioritized and are integrated into primary care. There's a growing focus on care models that emphasize cancer as a chronic condition, which promote early re-engagement of the primary care provider to support transition from the acute oncology setting back to primary care. But this is dependent on a few things. There needs to be stratification of the patient's risk of recurrence. There needs to be promotion of self-management for low-risk patients, and there needs to be mechanisms for rapid access back into the specialist setting if needed. These new models require acceptance by healthcare providers and patients. Unfortunately, this can be hindered by fears about the primary care provider's lack of cancer-specific expertise. So there needs to be shared care between the oncologist and the primary care provider, where both maintain ongoing involvement in the patient care. This is largely dependent on the availability of clinical information across the care continuum, and it requires acceptance by all cancer providers and the patient. So now we're going to talk about the general survivorship principles and the standards for survivorship care, which are to prevent new and recurrent cancers and other late effects, surveillance for cancer spread or recurrence, and screening for subsequent primary cancers, assessment of late psychosocial, physical, and immunologic effects, intervention for consequences of cancer and treatment, coordination of care between the primary care providers and the specialists to ensure that all the survivors' health needs are met, and planning for ongoing survivorship care. So there's an increasing number of patients due to improvements in screening, early detection, and treatment of many cancers. There's a growing older population. These patients have multiple comorbid conditions. Other factors affecting survivorship include your patient's self-awareness of their own increased risk and their knowledge of what they believe can be done to reduce their risk or improve adverse outcomes. There's scarce education and training for primary care providers on how to follow survivors. The cost of cancer care is increasing, as well as the cost for post-treatment care, and there are fragmented resources in the communities. So survivorship guidelines. So these are the most current guidelines from the National Comprehensive Cancer Network as of January of this year. The general survivorship principles to screen for subsequent new primary cancers. The survivorship assessment we'll get into shortly. Resources for healthcare professionals and patients, principles of screening for treatment-related subsequent primary cancers, preventive health, late effects, and long-term psychosocial and physical problems. These principles are meant to provide a framework for general survivorship care and management of potential long-term and or late effects of cancer and its treatment. We want to maintain and enhance wellness in our cancer survivors. We want to provide screening, evaluation, and treatment recommendations for common effects of cancer and its treatment. And then along with appropriate disease-specific guidance, these guidelines are meant to be a framework for the coordination of care between the healthcare providers to ensure that all of the needs of the cancer survivor are met. I briefly want to touch on familial and genetic risk assessment. It's important to do a periodic updating of your patient's family cancer history to reassess hereditary risk. Genetic testing guidelines evolve over time, as do new family diagnoses, making periodic assessment important. For your patients, you may want to consider referring them to a cancer genetic professional if there's a history of certain breast cancer survivors, epithelial, ovarian cancer, colorectal or endometrial cancer diagnosed less than age 50, anyone with pancreatic cancer or high-grade prostate cancer. You'd also want to consider this if your patient has a history of a rare cancer, if they've developed multiple primary cancers, if they had cancer at a young age, or for any individual who has one or more relatives with the same or related cancer. And the best example I would give for this would be the BRCA1 and BRCA2 related cancers. So if you have an individual or if there's a family history with, say, pancreatic, breast, ovarian, or prostate cancer, you may want to consider referring them to a genetic professional. And most of the time, these patients are sent for genetic counseling by their oncologist in their initial evaluation. But like I emphasized, this is why it's important to do periodic updating of the family history, because things do evolve over time. Assessment by a healthcare provider at regular intervals. So periodic assessment is recommended at least annually for all survivors to determine any needs and necessary interventions. Care needs to be coordinated between the primary care provider, the oncologist, and any subspecialty provider. And then transitioning them back to the primary care provider upon completion of treatment can be done when it's clinically appropriate. And a lot of this does depend on your patient's cancer type and their stage of disease. So patients diagnosed with an early stage who got through treatment relatively easy would be transitioned back to a primary care provider much sooner than somebody who was diagnosed with a later stage cancer and had a long treatment. I want to touch a little bit on preventive health. Cancer survivors are always asking me what they can do to help prevent recurrence or new cancers from forming. So a healthy lifestyle has been associated with improved quality of life and overall health. For some cancers, a healthy lifestyle has been associated with a reduced risk of recurrence and death. All patients should be encouraged to maintain a healthy body weight. And how can they do that? By encouraging physical activity. And I like to quantify that for the patients. So that means at least 150 minutes a week of moderate exercise or 75 minutes a week of vigorous exercise with strength and resistance training twice a week. You may want to consider medical evaluation for any of your patients prior to having them start an exercise program. Regarding diet, I tell them that there's not one particular diet that's encouraged. However, one that is generally high in fruits and vegetables, whole grains, and low in sugars is the best diet they can eat. That includes 2 cups a day of fruits and or vegetables, a diet rich in whole grains. They want to limit any red or processed meats. They really want to try and limit any sugary drinks or processed foods. And then with regard to supplements, their use is really only supported if there's a documented deficiency, if your patient has an inadequate diet, or they have comorbid indications for them to be on supplements. We also talk about minimizing alcohol intake. It's associated with an elevated risk for several cancers, such as breast cancer, throat cancer, esophageal, liver, and pancreatic cancers. I quantify this for women, 1 drink a day is considered the limit, and for men, it's 2. I also like to specify with them that binge drinking also has adverse effects. So this doesn't mean that they can drink more on the weekend and that it's okay, because it's not. I encourage patients to avoid tobacco products. You want to refer them for smoking cessation if needed. Encourage them to get adequate sleep, and also talk to them about sun safety. Immunizations and infections. So you want to encourage inactivated vaccines, vaccines made with purified antigens, bacterial components, or genetically engineered recombinant antigens in all cancer and transplant survivors. Ideally, vaccines should be given 2 weeks before the initiation of any cancer treatment or 3 months after chemotherapy has completed. However, the inactivated influenza vaccine can be given during cancer treatment. Some vaccines you want to use very cautiously in your immunocompromised survivors, such as MMR, varicella, oral typhoid, yellow fever, and rotavirus. It's important to assess your patient's risk factors for infections, knowing their disease status, knowing their counts. Are they post-splenectomy? Have they had prior chemo or radiation, cellular therapies? If so, when did they finish their treatment? And you just want to educate them on infection control practices as well. Hand washing, staying away from sick people. All right, so now we're going to get into the late and long-term effects of treatment, the physical and psychosocial, and we're going to run through the survivorship assessment. So before I go into all the topics for survivorship assessment, I just want to say that these are topics that are meant to be discussed periodically as you see patients in primary care. Just because of the time, not all of these areas are expected to be discussed in every single follow-up visit that you have with your patients. But we'll talk about cardiac health, mental health, including anxiety, depression, trauma and distress, cognitive function, fatigue, lymphedema, hormone-related symptoms, pain, sexual function, sleep disorder, and employment and return to work concerns. So cancer treatment can result in a variety of cardiovascular issues such as cardiomyopathy, hypertension, hyperlipidemia, arrhythmias, myocardial infarctions, and CVAs. Cardiovascular disease is still a leading cause of death in cancer survivors, and the risk varies with years from diagnosis, with the greatest risk being 5 or more years after diagnosis and completion of curative therapy. So some of the treatment-related cardiovascular risk factors would include your HER2-directed therapies. So this is your Herceptin and your Perjeta. These drugs can cause an asymptomatic decrease in your left ventricular ejection fraction. Although it does not appear to be related to cumulative dose, it's often reversible with discontinuation. So patients who are getting these drugs will often be getting echocardiograms every 3 months while on treatment. And even when treatment has ended, they'll be getting echocardiograms. I believe it's every 6 months for the first 2 years when they're finished with treatment. Your VEGF inhibitors and cisplatin can cause significant hypertension during active therapy, although long-term effects are unknown. Your anthracyclines with and without taxanes can be linked to cardiomyopathy, as well as a decrease in your ejection fraction as well. Although sometimes these patients do benefit from cardioprotective medications, but cardiotoxicity with the anthracyclines does not appear to be reversible and is related to your cumulative dose. Androgen deprivation therapy and aromatase inhibitors can have variable effects on lipids, and radiation can cause damage to microvasculature and can lead to an increased risk of coronary and carotid artery disease, depending on the radiation field. Patients who have had mediastinal radiation may be at increased risk for valvular degeneration and calcification. So you want to assess your survivors periodically for any pre-existing and emerging cardiovascular disease. You want to know their cancer treatment history, including the regimen, the dose, if they had radiation, how much did they get, and what was the field that was involved. And then you want to talk to them about diet and exercise habits, as well as cigarette and tobacco use, because controlling risk factors can decrease their risk. Cancer survivors are at an increased risk for mental health issues such as depression, anxiety, distress, and fear of recurrence that may persist for years after diagnosis. Fear of recurrence can lead to increased symptoms when surveillance testing or follow-up appointments are scheduled, particularly around the anniversary of diagnosis or treatment anniversaries. Some fear of recurrence is normal, but any excessive fear can lead to decreased quality of life. Medical, psychosocial, environmental, and psychiatric health factors should be considered when screening for distress, anxiety, and depression in survivors. It's important to monitor distress, especially at times of new diagnosis, transitions in care, any significant loss or major life events. And you want to encourage patients to recognize their emotions, encourage them to join support groups, find ways to manage stress, to make healthy choices, and to be well informed. Cognitive function. You'll hear a lot of patients complain about chemo brain. They'll complain that they feel that they're just in a fog. There's a lot of evidence to support the validity of patient-reported cognitive dysfunction associated with cancer diagnosis and treatments. Unfortunately, there's no brief screening tool for cancer-associated cognitive dysfunction. Tools like the mini mental state exam and similar tools lack the sensitivity to detect the subtle decline in cognitive performance that's commonly seen in cancer survivors. Patients who report cognitive dysfunction should be screened for potentially reversible factors such as depression, fatigue, and sleep disturbance. There's limited evidence to guide management. However, patients benefit from validation of their symptom experience, a thorough evaluation of their concern, and education. Fatigue. Fatigue is a subjective experience. It can persist for months to years after a cancer diagnosis. Patients who've had chemo, radiation, endocrine or targeted therapies are all predisposed for cancer-related fatigue, but you can see it in patients who've been treated with surgery alone. Any fatigue that initially presents after the completion of adjuvant therapy or worsens during this time warrants further investigation. You want to make sure that they don't have a recurrence. So you want to do a focused fatigue history, know their disease status, assess for any contributing factors, sleep disturbance, pain, what's their nutrition, what medications are you taking, as well as physical activity and sedentary behavior. We talk to patients a lot about fatigue and encourage them to be as physically active as possible. It can help with fatigue, and it also can help with their mental health. Lymphedema is most often diagnosed within 18 months of treatment. Early detection is key for optimal management. The risk factors include surgery and radiation to the axillary, supraclavicular, cervical, or inguinal lymph nodes. Patients who are obese have a larger number of nodes involved, or any localized infections are at increased risk. And patients who've had sentinel node biopsy also have increased risk. However, the risk is less than when compared to a complete dissection. Treatment can be varied as there are various stages of lymphedema, but it involves self-care management. These patients can be referred to a certified lymphedema specialist. They can be fit for compression garments. Manual drainage and lymphatic massage can be helpful, as well as physical therapy. Hormone-related symptoms in the female. So many survivors may experience symptoms regardless of their ovarian function. You may want to consider drawing serial estradiol levels on these women to confirm their menopausal status, especially if they have a history of prior chemo, pelvic radiation, or for your survivors on tamoxifen. Some of the menopausal signs and symptoms that you're going to see are the vasomotor symptoms, the night sweats, the hot flashes, the cognitive dysfunction. They complain of vaginal dryness. They complain of urogenital complaints, sexual dysfunction, arthralgias, myalgias, and fatigue. And then there's the menopause-related health risks, such as osteoporosis, which increases their risk for bone fracture, the cognitive changes, cardiovascular disease as well. And I do just want to make one note for your female survivors who are amenorrheic, but do not meet the definition of menopause and are sexually active. It's extremely important to counsel them on the need for contraception in order to avoid unwanted pregnancies. And now the hormone-related symptoms in male patients. For your male patients who were treated for non-prostate malignancies, those treated with radiation, chemo, or surgery may have hypogonadism. It's important that they're evaluated for biochemical evidence of hypogonadism, and they can be treated with testosterone for their symptoms. For patients who have been treated for prostate cancer, initiating treatment for hypogonadism is very controversial, and this is something that you would want to talk to their oncologist about. And then for male patients who are being treated for metastatic prostate cancer, androgen deprivation therapy is the main therapeutic approach. So what are some of the androgen deprivation therapy related symptoms and health risks? So androgen deprivation therapy has effects on body weight, visceral adipose tissue, insulin sensitivity, metabolic syndrome, and dyslipidemia. These are your drugs such as Casodex, your Lupron, your Zoladex. They can cause anemia. They can cause bone and muscle aches. They can predispose them to cardiovascular disease, mood depression, cognitive dysfunction. They have decreased muscle mass. They have increased body fat, decreased penile size, testicular atrophy, as well as the vasomotor symptoms that you see in women, the hot flashes, the nausea, and the night sweats. So what are some of the treatment options for vasomotor symptoms in men and women? So unfortunately for those people who've been treated for hormonally mediated cancers, hormonal therapies are generally contraindicated. You'd also want to use hormonal therapy very cautiously in any patient who has an increased genetic cancer risk. So some of the non-hormonal options, prescription alternatives, drugs like venlafaxine, gabapentin, and oxybutynin are very helpful. Gabapentin's been used to treat hot flashes and improve sleep quality. Venlafaxine has been used many times to help alleviate hot flashes as well. And then oxybutynin can reduce the frequency and intensity of hot flashes, as well as help alleviate the symptoms of an overactive bladder. There's over-the-counter options, there's integrative therapies, and lifestyle modifications as well. We encourage acupuncture, yoga, hypnosis, and weight loss has been beneficial. Pain. So on all these patients, a comprehensive pain assessment is important. Any new or acute pain, you want to consider recurrence or progression of disease. And then chronic pain, it's not uncommon that these patients have what's known as a cancer pain syndrome, which is defined by the association of particular pain characteristics and physical signs that are specific consequences of their underlying disease or its treatment. And neuropathic pain would be an example of this. Pain relief requires a multimodality approach. For your patients that need opioids, you want to start them with the lowest dose possible and also incorporate non-opioids. You want to use physical modalities such as heat, colds, massage, physical therapy, occupational therapy, acupuncture can also be helpful. And you want to reevaluate their effectiveness and necessity of opioids regularly. You want to provide them with psychological support as well. And I also just want to touch a little bit on medical marijuana, because I know that's an important topic these days. Per the NCCN, there's currently not enough data to make any guideline recommendations for the use of medical marijuana. Sexual function, it's important to screen your patients regularly, ask them about sexual function. Some of your female patients may complain of vaginal dryness, low or diminished libido, or pain with sexual activity. Your male patients may report erectile dysfunction, low libido, problems with orgasm or ejaculation. Whenever possible, survivors should be referred for further sexual health evaluation. You can send them to sexual health therapists, psychotherapists, gynecologic or urologic care as well. And then you just want to reevaluate and discuss the impact of treatment with them. Sleep disorders. So it's important to screen regularly for sleep disorders or sleep disturbance, such as insomnia symptoms, restless leg syndrome, or obstructive sleep apnea. You want to review general sleep hygiene measures with them, which includes limiting their use of cell phones, tablets, computers, anything that gives off a bright light within a few hours before bedtime. You want to encourage regular exercise. You want to talk to them about limiting alcohol, nicotine, caffeine, avoiding large meals at least 4 hours before bedtime, and then enhancing a sleep environment is important. Employment and return to work. So this refers mostly to individuals who are post-treatment and individuals who are living chronically with cancer. Symptoms affecting work can fluctuate with treatment and or disease status. Employment helps protect many survivors from financial toxicity, as health insurance access is frequently tied to employment, at least in this country. So you'll see many survivors return to work even when or if they're not fully recovered. It's important to discuss their concerns, their needs, their goals, and their desires related to work. So when they're diagnosed, what are their expectations upon the completion of treatment as far as going back to work? What is their job? Do they have a physically demanding job? Do they expect that they'll be able to return to that, or are they willing to accept maybe that they'll have to take a job that's not as demanding? You want to assess their abilities related to work. Are there barriers? Do they have any treatable contributing symptoms or comorbid conditions? And then survivors should be offered information to help them understand their ability to work, take into account their finances, personal and family needs, and potential work accommodations. Now we're going to talk about screening for subsequent primary cancers. Screening, so this is a joint effort. Screening for primary cancer should be a shared responsibility between the primary care provider and the oncologist. New primaries can occur years after treatment when the oncologist is no longer involved in their care. Overall, the cancer rate is higher in survivors than it is in the general population. This is due to a variety of factors and includes genetic susceptibilities, family history, shared etiologic exposures, and mutagenic effects of cancer treatment. Treatment-related subsequent primary cancers can vary with the type of anti-cancer treatment and are associated with radiation and specific chemotherapeutic agents. Healthy lifestyle, behavioral counseling, modifying health behaviors such as weight management, alcohol consumption, and smoking cessation can help patients modify and reduce their risk factors. 20% of all new cancers are diagnosed in people who have a history of cancer, and this number is expected to increase. Male survivors have an 11% higher incidence and a 45% higher risk of dying from a subsequent primary cancer when compared to the general population. And some of the secondary subsequent cancers that we see in male patients are lung, prostate, colorectal, bladder, and urinary. And then female survivors have a 10% higher risk of developing a subsequent cancer and a 33% higher risk of dying from it. And then the common subsequent cancers seen in women are breast, colorectal, and uterine. So the treatment-related risks of subsequent cancers related to radiation and chemotherapy. So these cancers related to radiation are most often not seen for many years after treatment. It can be at least 10 plus years before they develop. can be related to dose and the number of years since treatment. If your patients received radiation, it's important for you to know how old they were at the time of treatment, what was the target field, did they receive chemotherapy, and do they have a history of smoking? And then for chemotherapy, these patients have an early to late risk of leukemias. It's dependent on drug type. The higher doses of drugs, the higher dose intensity, and the longer treatment time are associated with increased risk. So I just want to go over this chart with you a little bit. This is talking about your treatment exposure for patients who've received radiation, as well as the subsequent primary cancer risk and any screening or recommendations that are to be considered. So for any of your patients who've had radiation for head and neck cancer, they have an increased risk for mucosal head and neck cancer. You'd want to consider an annual head and neck exam and or otolaryngology referral if they're not already being followed. They have an increased risk of thyroid cancer. An annual neck exam should be considered. For some of your Hodgkin's patients who were treated many years prior with mantle or chest radiation, your female survivors are at risk for breast cancer. You'd want to consider a breast MRI and mammogram are recommended annually, starting at age 30 or 8 years after the completion of radiation, whichever occurs last. They are at increased risk for lung cancer. You'd want to image them as clinically indicated. And obviously, if your patients also have a history of cancer, and if they meet the criteria for lung cancer screening, then you would want to screen them regularly. For your patients who've received radiation to the abdomen, frank or pelvis, they're at increased risk for colorectal cancer. So colorectal cancer screening would start at the age of 30 or 5 years after they finished radiation, whichever occurs last. And I do want to point out for the patients who've had radiation, they all have an increased risk of skin cancer. So it's important that these patients are getting an annual skin exam, and you can refer them to dermatology as well. So some of the treatment-related effects. So late and long-term effects. Your late effects can develop months to years after treatment has ended. Your long-term effects may develop during treatment, and they can continue for months or years. So some of the common surgery-related effects: pain or chronic pain syndrome, lymphedema. They can have functional limitations. They can have issues with body image, infertility. The colorectal patients can have ostomies. These patients can suffer from sexual dysfunction. Your chemotherapy-related effects, cardiac dysfunction we talked about already, but with the anthracyclines, doxorubicin, daunorubicin, your HER2 antagonists as well. There could be pulmonary fibrosis and toxicity in patients who've received bleomycin or methotrexate, as well as trastuzumab. Neuropathy is quite common with the platinum-based agents, cisplatin, oxaliplatin, your docetaxel, paclitaxel. Hearing loss can be linked with cisplatin, and then premature menopause or infertility is often seen with cyclophosphamide, cisplatin, methotrexate, and doxorubicin, to name a few. Some of the effects from hormonal therapy. So for your patients on tamoxifen, they do have an increased risk of clotting. So you want to know if they have any history of DVT or PE, any history of factor V Leiden deficiency, or any antiphospholipid antibodies. They do have an increased risk of uterine cancer. So it's important that these patients on tamoxifen see their gynecologist regularly if they have an intact uterus. They can suffer from hot flashes and vaginal dryness. Your patients on aromatase inhibitors are at increased risk for osteoporosis. So as long as they're taking an aromatase inhibitor, they need to have bone density testing every 2 years. They can complain of musculoskeletal pain, hair thinning, and dyslipidemia can be a common side effect for your patients on aromatase inhibitors as well. And then for your patients on androgen deprivation, they can also have hot flashes. You may see QT prolongation. They're at risk for osteoporosis, metabolic syndrome, breast tenderness. There's the vasomotor effects, emotional lability, and fatigue. Immunotherapy-related effects. Immunotherapy has been very important in cancer treatment over the last 10 years or so. So these immune checkpoint inhibitors can trigger an immune response that causes inflammation to organs in the body, not just the organ that that's being treated. So the side effects really can run from head to toe. You can see neurologic disorders, you can see hypophysitis, you can see thyroid dysfunction, pneumonitis, colitis, skin, you can have dermatitis anywhere on the body. You'll see some transaminitis with these patients, as well as pancreatitis. And oftentimes the side effects generally occur within the first few weeks to months after starting treatment. Depending on the severity of their side effects, these patients may need to be treated with steroids, and potentially their treatment may need to be stopped for a period of time. And then generally speaking, once treatment has been initiated, their symptoms do resolve within a few weeks. Radiation therapy side effects. I do want to point out, as someone who works in radiation oncology, that it's important to consider that the side effects are related to the part of the body that is treated. So for patients who have had brain radiation, they may have headaches, they may have fatigue, they may have some memory loss, particularly if the hippocampus was involved. For your head and neck patients who've received radiation, they could have chronic dry mouth, they may have jaw stiffness, and dysphagia. Anyone who's had radiation to the chest can have some dysphagia, shortness of breath, maybe some shoulder stiffness if the brachial plexus was involved. Radiation fibrosis is a possibility, although steps are certainly taken to avoid this risk. And then patients who've had abdominal or stomach radiation can have nausea, vomiting, loss of appetite. They can have cramping and diarrhea. And then pelvic radiation can sometimes cause loose stools, rectal bleeding, sexual dysfunction, incontinence, bladder irritation, and menopausal symptoms. I want to talk a little bit briefly now about survivorship care plans. This may be something that you're familiar with in your practice. These are designed to educate patients and primary care providers regarding general survivorship-related needs based on the patient's individual treatment summary. They're developed to provide guidelines for follow-up care. They started in the oncology setting. When they're handed out to patients, they're given multiple copies and they're encouraged to be shared with their primary care provider. They're generally given to patients upon the completion of active treatment. They're designed to be given within 6 months completion of active treatment and no later than 12 months from their date of diagnosis. The Commission on Cancer Standard 4.8 is the most current standard. And they encourage that patients receive a survivorship care plan, but delivery of these care plans is no longer a required component of the standard. So you may have seen more of these in the past, where we had a 50% benchmark that 50% of all patients who had completed treatment receive a care plan. Here at Stony Brook, we still do utilize giving out survivorship care plans as a service that we offer here. So what's in a survivorship care plan? I'll show you a template on the next page, but it involves the names of the treatment team, other care providers. It includes a treatment summary, which has any ongoing medications, particularly hormonal medications that your patient's still taking. It goes over possible short and long-term effects of treatment. And then it really highlights the frequency of surveillance testing. So who is ordering their follow-up testing and how often should they be seeing that individual? We also talk about cancer screening recommendations, not just for the type of cancer that they've had, but also any age-appropriate cancer screening guidelines are important. It provides them with recommendations for follow-up with each provider. We talk about support services that are offered here at Stony Brook and what's recommended for them. And then if they have had any genetic testing in the past, they should already know those results, but we include that genetic testing in the care plan as well. So this is a copy of the ASCO Survivorship Care Plan. This one in particular is for breast cancer. So I'm just going to point out, so up here is just some general information. You can see the patient name, demographics. We list all their healthcare providers for their team. So the surgeon, their radiation oncologist, their medical oncologist would be here. The treatment summary. So you would pick the laterality for breast cancer or if it was bilateral. There's an area for their receptor status, if they're estrogen and progesterone positive, or if they're HER2 positive, when they were diagnosed, what year, particularly we put the month and day as well, and how old they were at the time of diagnosis, their stage, treatment completion. So if they've had surgery, what was the date? What were the findings? Did they have a sentinel biopsy or an axillary dissection? If they had radiation, yes or no, what was the body area treated? We generally include the dose as well and the dates that they were treated. And then this area here is for any kind of systemic therapy, whether it's chemo, hormonal, was it before or after surgery or both? We put the treatment dates here, we put the number of cycles, and if your patient had any dose reduction, if their treatment was discontinued due to toxicities or side effects, we like to include these notes here as well. And then any ongoing treatment. So here, if they were on tamoxifen, You would see the plan duration is generally 5 years, sometimes longer. What are possible side effects? And then this would continue on to the next page. And I apologize, I don't have the next page, but it would include your aromatase inhibitors. And then it would also talk about side effects of radiation, and it would provide them with a follow-up schedule for who they should be seeing. So it would say their breast surgeon for mammogram, for example, annually. It would encourage them to see you as the primary care provider at least annually for other cancer-related screenings and general wellness visits. Female patients, we have their gynecologist listed there. We talk to them about colorectal cancer screening. The male patients, we talk to them about prostate cancer screening. I refer patients to dermatologists if needed, if they don't already have one as well. So what are some of the barriers to survivorship care? There can be a lack of coordination and communication between primary care providers and cancer care providers. It's hard to provide survivorship care if you're not receiving treatment summaries and if you don't know what's happening with your patient as it's happening. There can be a lack of survivorship training, an absence of agreed upon standards of survivorship care guidelines for primary care providers. And this could be generally limited to detecting recurrences and second cancers. So we need discharge care plans that are clear to both the primary care provider and the oncologist, as well as the patient. We need to overcome gaps between cancer specialty guidelines and primary care clinicians' perspectives regarding survivorship. And we need to improve communication between multiple providers at multiple sites of care. It's not uncommon for patients to have surgery at one institution, chemo at another institution, and radiation at another site. So what do we have here at Stony Brook for survivorship? Some things have been limited due to the pandemic, but we have various support groups. Some of them are still virtual, but many have now resumed being in person. We do have physical activity classes, which I think are still on hold, but we have yoga and we have Strength for Life. So for patients who want to be physically active but aren't comfortable joining a gym, but want people to exercise with, we do have classes here. Nutrition, we have some wonderful nutritionists who are happy to see patients in person or via telehealth. They will go over cancer nutrition with them. We have a Healthy Forks program. Pre-pandemic, there were trips to the farmers market where patients really benefited from all of this information. We refer patients to financial service resources if they're having, if they need extra assistance. We refer a lot of patients to social work and psychiatry for psychosocial support, and just to discuss community resources. And then we have department-led survivorship visits, which do vary by department. Generally speaking, the survivorship visit is the first one that happens upon completion of active treatment. It could be anywhere from a month to 3 months to 6 months after treatment's finished. And that's when they're given a care plan and we go over everything with them. We generally like to make sure that they have gotten through and gotten over any of the side effects that they had during treatment before we discuss survivorship with them. So what can you do to enhance survivorship care? Know your patient's cancer history, clarify it with them. Consider the cancer history when you're evaluating new problems. You want to participate in continuing education on cancer treatment and side effects whenever possible. It's important to maintain complete cancer screening coverage for any survivors. Utilize survivorship clinics or consultants if available, like myself. And if you have any questions regarding your patients or their treatment, please reach out to the local oncologist with any questions. I listed some resources here, including American Cancer Society, National Comprehensive Cancer Network, CDC, American Psychosocial Oncology Society, Americans with Disabilities Act, the Cancer Legal Resource Center is very useful. Live Strong at the YMCA, Menopause and Sexual Health, or just a variety of resources that can be utilized. And thank you very much. I really appreciate everybody's time. And if you have any questions, I'm more than happy to answer them.
Thank you, Claire, for that presentation. If anybody has any questions, feel free.
I have a question. First of all, it was a wonderful presentation. Thank you so much.
Thank you.
For the survivorship care plans, like if a person is getting care from multiple providers, like or physicians, that let's say they're, they're seeing an oncologist, they've got radiation therapy going on, and there's a radiation therapist, and then maybe they're getting chemotherapy, or maybe they had both. Who actually among the team fills out the survivorship care plan?
Great question. So it's generally whoever is generally providing the most care. So if they had surgery and radiation at one facility, it's usually that facility that is doing it, but there is some coordination involved. We'll often be calling other institutions to get their records to add that information onto the care plan. Some other centers are very good at giving out care plans as well, but generally speaking, if you've provided, I think it's 2, even if you've only provided one aspect of their care, you are considered responsible for providing the care plan.
And does the plan get like physically handed to the patient, or is it posted
Yes.
on the portal, or does it get on like health information exchange, or how is that communicated?
It needs to be, part of the standard is that it needs to be discussed with the patient. So prior to COVID, we were doing all the visits were in person. You can discuss it with them over the phone. So whether it's something that's sent to them then in the mail, and then there's a follow-up phone call to go over it, but it has to be discussed in person. It can't just be sent through a portal. It can't be sent via email. So this way we go over everything with them, and I tell them, we're going to look over it together now, but I also want you to look at it when you go home. And if anything needs clarification, to please call and we'll fix it.
So if a patient comes to you and they don't have, they come and see you, the primary care physician, and you don't have a care, they don't come with a plan, do you just tell them go back to your oncologist and get one, or you reach out to the like, what would you do?
You can, yes, you can. I mean, so like I said, unfortunately, the standard, the COC standard has changed a little bit. So it used to be that 50% of all patients who completed active treatment needed to be given a care plan. So we were seeing more of them. Unfortunately, now that standard has changed with the focus on sort of different aspects of survivorship. So you may not see that many care plans given out anymore. But you certainly to call the oncologist, call the radiation oncologist, call the surgeon's office for records if they're not able to generate a care plan for you. A lot of the care plans too are, unfortunately, the data is input by hand and not just generated automatically through a program. So they are time consuming to put together, which can be a downside.
Okay, thank you so much.
You're welcome. Thank you.
Claire, I
Thank you,
have a
Claire,
question.
for
Oh, I'm
doing
sorry.
this.
Oh,
Thank you,
thanks,
Claire,
Dr. Rio.
for doing this. Your contribution to the department, to the cancer center, and to the patient in particular is enormous.
Thank you.
Thanks, Dr. Rio. Claire, I have a question. You mentioned the distress tool. Is there a separate NCCN distress tool for survivors, or do the survivors ever get a distress tool when they come for their survivorship care plan meeting?
It's the same distress thermometer that's given to them usually at their first appointment. We try to give it to them when they come in for treatment, but it's hard sometimes because sometimes they're being given a care plan a week after they finish treatment. Sometimes it's given to them 3 months or 6 months or sometimes a year after treatment. But we do try and go over the distress tool with them as well.
Thank you.
You're welcome. All right, well, I want to thank everybody for their time and attention. I really appreciate it. My email address is here, so if you have any questions afterwards that you think of, or if I can help you to be a resource in navigating survivorship, please feel free to reach out.
Thanks, Claire.
Oh, thanks very much. Have a good day, everybody.